So just a little bit about myself, Kim Mcpherson. I'm class of 1984 in the MBA MPH program. And I had an origin story that's kind of similar to some, that I went to UC Davis in the 80s undergrad thinking I was going to be a doctor, pre-med. Went through a couple of quarters of OChem and whatnot, and I was living on a dorm floor that was all pre-med, which was a blessing and a curse perhaps, because I realized quite quickly, not for me, not what I want to do with my life. So I had to recalibrate what I was going to do when I grew up, and wasn't really sure. And I was fortunate to have a great mentor at an internship who said, you know, what about health insurance? It's this interesting mix of technical things which you seem to like, but it's also people's lives. And she really helped me understand the role that health insurance plays at a macro level, but also at a human level. And so that's what I did. I went to work for a health insurer right out of undergrad, and 5 years later found myself here in the MBA and PH program, where I gained a ton, and we could talk about that later. And then I went and did consulting in health services for about 12 or 13 years before family reasons brought me back here as faculty, and I've now been here split between the School of Public Health and the Haas School of Business for over 16 years. So I teach in the program, run different master's programs in both ends. Also have a research center where I spend a lot of time thinking about biomedical and digital innovation and how it gets brought into a system that doesn't embrace change easily. So that's a little bit of me. I would love to first introduce Julie Brown and ask her to tell you a little bit about herself, what brought her here.
Okay.
And we'll start from there.
Great. Thank you. Thanks, Kim. And thank you all for choosing this session. It kind of feels good that people showed up. We always wonder about that kind of thing. My name is Julie M. Brown, and I'm the principal of Julie M. Brown and Associates. I'll tell you about that in a moment. I'm a 1985 graduate of the MBA MPH program, so way back when. The program at that point was a 3-year program. You did a residency, which is required as part of the program. And you also had to write a thesis. So all that application was one of the things that drew me to the program. Let me back up a little bit and tell you how I landed here. I was always interested in healthcare, don't particularly know why. Did my undergrad in psych and social welfare here at Berkeley, and then graduated with a really bad job market. And several months after graduating, I finally landed a job as a customer service supervisor at Blue Cross. And that job and my experiences were fundamental to shaping my desired future, and they're tenets that I still practice today from lessons learned on that job. Nothing that you would expect in terms of high-level stuff. I learned all from a job that I loathed. I absolutely hated this job. So the job itself taught me quite a lot, meaning that I already had supervisory experience, I already had healthcare experience. I wanted to be in direct care, but couldn't find a job in the bad job market, had a lot of competition. In the customer service job, what I learned that stays with me today, a couple of things. One is I did not see any support for frontline staff making key decisions on behalf of the organization. They didn't have systems to support their very challenging work. They were angry a lot. If you can imagine customer service, people don't call up to say, good morning, I want to thank you for being there, have a good day. Doesn't happen. So they were angry, they were frustrated quite a lot. We didn't see senior leadership at all, walking around, asking, et cetera. Whenever we proposed solutions, we always had barriers. So those are some of the things that I still think about today as I'm sitting and doing work with clients or in thinking about what's important to me in terms of next steps. So I wanted to come back badly, very, very badly. I got accepted to the program. I actually applied to Columbia and UCLA, got into those, but Berkeley's was an inaugural program and it was integrated. So it meant I needed to show up and they had choreographed what courses we took, what experiences we had, et cetera. And I realized that I put myself through undergrad work and I stayed out another year because I was worried about money. I did not want to work in my graduate program. And when I knocked on the door again and said, hi, I'm ready to come back, they said, oh, we forgot about you. So again, here's some history that some of you will probably go, don't get this today. The reality was at the School of Business at the time and the School of Public Health, the tensions were phenomenal around this joint program. From a funding standpoint, from a philosophy standpoint, I have a big voice, so if that goes out, no problem. From a philosophy standpoint, from just the orientation. So the message is communicated to us in the business school is you're taking a spot up for a real MBA, and then you go all the way to the other side of campus and go to the public health program. It was business and healthcare, heresy. So that was the environment way back when, and I know some of you who might have been in the joint program can't imagine what that was like. But I came in, wanted to come back, remember that job I loathed, came back. I was a cohort of one, didn't want to stay out any longer. So there was the inaugural class before me, with classes after me. And let me back up and just say, here's where I am today. So I graduated. I have actually done a number of different things. I'm a former hospital CEO for Kaiser Permanente. I worked as a assistant hospital administrator and executive service line person over their South Bay facilities with support services. I worked at Alta Bates and Herrick Hospital as a service line director and a new business development manager. But for the past 25 years, I've had clients in a firm that focuses on strategic planning, leadership development work, and operations improvement. And I absolutely love it. So I'll stop there and let you go on. Excuse me. I talk really fast too. So if you haven't noticed that, if there's any questions you have, tell me to slow down. I'll do that.
Well, great. Well, thanks, Julie. So next I would like to invite Lauren Dugard Thomas to share a little bit about her origin story and tell you a little bit about her journey.
Yeah, so I'm newer. I'm graduated in 2017 from the dual program. Until we got on the phone, did not know it wasn't always called dualies. So I benefit from Kim's brilliant design of the program, and it felt like breathing. Very integrated, very easy. Love my class. We're very connected. We always say that the lines of companies don't divide the lines of our impact. So we're always sharing information and trying to help each other find jobs, find resources, solve problems. So had a great experience here at Haas. And I've always been in healthcare. So growing up, my mom was on the business side of biomed engineering at Case Western Reserve University in Cleveland. And so I grew up like running up and down the halls after work, bothering all the scientists and like professors and going into their labs and learning things, and have always challenged the status quo, kind of questioned, okay, this is healthcare, but how can we do it better? So I always, like to think that I decided to do bioengineering myself, but I have to give my mom credit a little bit. And so my first kind of flavor of trying to drive impact in healthcare was in bioengineering. And I thought I wanted to do pure research, found out I liked people too much, not a ton, but more than, more than being in a lab by myself. And so I decided to go directly into industry. And I was at Johnson & Johnson for quite a while in a variety of engineering and ops roles. And really felt like I was having a tremendous impact on healthcare. I was like, I'm launching new devices. This is fantastic. This is what I've always wanted to do. And then the ACA rolled out, and I started volunteering at my church. There's a partnership between my church and a local hospital to be an ACA ambassador and start explaining healthcare to folks for the first time who were signing up for coverage and had tremendous gaps in coverage or may never have had healthcare coverage. And I was like, great, I am solving the wrong problem because my own family can't access all these devices I'm designing. They don't have coverage. And they're terrified of the healthcare system and terrified of physicians. And guess what? They have right to be. Because my grandfather grew up, where my grandfather grew up, dentists weren't even using, anesthesia for Black patients. So I was like, I have this unique perspective that I thought everyone had. I thought everyone wanted to solve the same issues. But it actually turns out when I come into a room, sometimes I'm the only person that has this lived experience that can provide insight to how we're looking to solve problems. And so I started asking really interesting questions to my leadership. How do we decide what devices to go after for the pharma side? How we decide what drugs we want to target or what indications, and how do we do clinical studies with diverse populations? And no one that I was interacting with could answer my questions. I'm sure there were tons of people who could, just not where I was in engineering and in ops. But they could write really great recommendations. So they sent me back to school to answer my questions. And I always wanted to do my MPH. I was like, these are the problems I want to solve. This is where I need to be. And it was kind of, for me, the opposite of a lot of dualies who wanted to do their MPA and wanted to focus in healthcare. I wanted to do my MPH, but wanted the MBA because I wanted to be in the right rooms. And I wanted to be able to hold my own and be able to show the business benefit for why we should be making the impact that, to me, was so blatant that needed to change. And I love, Kim, how you started out kind of saying, we're waiting for the rest of the world to catch up to what folks from Berkeley know is like, we have to change this paradigm. We have to change this story. So I loved being at Haas and kind of bridging the 2 degrees. And then decided to go right back into more care delivery side. So I was at Kaiser for a while and then moved over to the health plan side. And now I'm at Blue Shield and I lead an enterprise strategy team. So really looking at how we align enterprise priorities to transform healthcare aligned with our ultimate objectives. Like how do we create impact? How do we measure that impact? How do we prioritize what to impact? How do we respond to sudden things that come up like COVID or even issues that we don't know yet what the ROI will be, which is often the challenge when you're focusing on health disparities or you're focusing on social determinants of health. Where in the continuum are you going to make impact, and how will you know what you're doing will move the needle? Or do you just do it because it's the right thing? So how do you create the business case for that work and prioritize it against must-do enterprise initiatives? So I like where I am. I think when I talk about it now, it makes sense, but it's certainly been decision points at every turn. So.
Well, as you can see in the book, in fact, all of our stories, I think we're people that really think it's important to take these multiplicity of perspectives and bring that forward. We don't like to solve challenges just with a single lens, and I think that's really a hallmark of the program. I would just say here generally, and I love that Julie was able to share some of the early history, the program really has evolved, the dynamics between the school, and I just think the general ecosystem. And so now the program has gone from 1 to 5 to 15. It's now over 20, 25, every cohort. And I think that growth is part because we've really worked hard to smooth out that integration and make sure the program's really seamless. But I also think it just reflects that desire and that appreciation that if you want to solve the tough problems, you do need to have this fluency, is how I describe it. Not just dabbling and taking classes either to get in the right room with some business fundamentals or to really understand what the term SDOH, social determinants, means. If you want to really make change, you probably need the fluency. And then for those that want to go that route, the dual degree has just become a wonderful thing. I would also just say at Haas more generally, we see the footprint of health and healthcare and social impact really growing. All the healthcare classes tend to sell out now. Usually my class that I teach in the fall, I've got maybe 10 or 11 spots out of 75 for people elsewhere on campus, MPHs, Masters of Social Welfare, but now I don't. The class is completely subscribed by MBAs, who, even if they are healthcare curious, as I like to call them, they really see the importance and how this area touches all facets. So if they're going to be in finance or tech or any facet of advisory, or more broadly, they appreciate that whether it's for themselves as individuals or more broadly, this is really important. It really matters. It touches so many things. And the fact that everyone in the class now wants to start with appreciation of health equity. What does that mean? How do social determinants come into play? I think is really just a hallmark of what Haas brings and who it attracts to the MBA programs. And so I'm just really, really proud of that and that evolution and growth. I wanted to talk a little bit about other influences in the choices that we make. One of the great things about healthcare and careers in it is that there's lots of different paths that you can take, and that you can take knowledge from one and move it to another. And you could, I think, already hear from Julie and Lauren, and maybe perhaps from myself, that we've been able to do that. And sometimes we've been trying to solve a challenge in a certain way, or we're interested in a problem from a certain angle, and then we recognize that we need to move forward or move elsewhere, even if it's unfamiliar or uncomfortable, and try to engage and solve it that way. Maybe I'll go back to you first, Lauren, and just talk a little bit. Maybe you could share a little bit about what's it been like trying to sort of pick up and move from one sector or another, and what's driven you to do that? You started to talk about how you recognize that people couldn't have access to the wonderful innovations that the firms you were in were developing. Are there some other influences or things that have driven your choices, or that you think will continue to drive your choices as your career continues to evolve? Yeah. Any thoughts, any previews of where you might go next? I know Blue Shield would hate it if you left, but should you set your sights elsewhere, where might that be?
Yeah, I mean, I feel I'm at another reflection point now, because I've always been very driven by name brand when it comes to education, when it comes to where I work. Again, this is my lived experience, wanting what my bullet points say on paper to validate my expertise. And I think I'm now at this point where I have enough bullet points that I can have more flexibility for myself. And, not only try to steer very large ships, a half a degree and make a huge impact, but also think about how I move much earlier in the continuum of impact. And, work with nonprofits, work with smaller entities that are working on very focused issues. So I feel like that is more in my future, that I feel a sense of freedom and a determination to align my life with my values. And I think that, certainly the pandemic, becoming a mom, finally reaching a leadership level, there's so many things that have happened in the past couple years for me that I am feeling full and like the very pie in the sky, gee, it sure would be good to get here. I'm like, oh, this was faster than I thought. Now what can I do? So I think I'm at another reflection point now. But in the past, absolutely what's driven decision making is how do I get to the highest level of a room where I know my voice or voices like mine are not often heard. So that's kind of where I am now, and I haven't figured out the flavor yet of where I'll move, but we'll see.
Julie, how about for you? What's been sort of North Star for you as you look back into where you are today?
I think I had a different experience in that my professional life was chaos. So I've already shared that when I finished my undergrad work, it was a very bad job market. And as I explored getting back into direct care, I knew from a skill standpoint and a credibility standpoint that I needed to get the quantitative background. And that was part of the driver of going back for an MBA. When I did that and I graduated, chaos again. So we were going through a recession. And in the first 4 years of having full-time paid work post-graduation, I experienced multiple labor stoppages, consolidation and acquisition, restructuring changes. Every job I had for the first 7 years of my professional career had not been there 2 years previously. So I think I learned very early on, for me, what worked was exploring what I wanted to do from the standpoint of competencies and skill sets. And I wasn't afraid to take lateral roles. I wasn't afraid to volunteer for things that would expand my understandings of the work that I was doing and felt competent around. I wasn't afraid to go out and try different structures and to be in different places other than the traditional career path. What I will say that I had the gift of two experiences. One was, usually I walked into a room and I was the only person of color and the only one with ovaries. So quite honestly, I had lots of challenges early on in terms of trying to gain credibility, being at the table, having the impact that I wanted to have, having the assignments that I wanted to have, not having to sit down and argue about my credibility or my worthiness to be at the table. The second piece is that very early on, I had an experience with sexual harassment. And because of the individual who was in a position of power, the only option that I saw, and I never spoke with anybody that I worked with at the time about this, the only option I saw was leaving, because there was not a way to work it out. There was not a way to get it to stop. And I planned on doing that. So the gift around that was sitting down and saying, where do I want to be? What do I want for myself? What are the experiences? And I came up with some guiding stars. Just for me, it's about autonomy. It's about social impact and being able to make a change to the constituents, to the clients, to the customers that matter most to me. It's about working with a team of people that are creative and aren't afraid to take risks. So developing a litany of things and trying not to look at that potential job loss as a failure was one way of keeping myself upright. Now, in the meantime, a physician that I did not know very well cornered me in office and said, your behavior's changed, and essentially said, is this harassment going on with you? And I couldn't and didn't speak to it. I wouldn't acknowledge it. And he said, don't do anything yet. I'll take care of it. And within 2 weeks, the situation that I'd been experiencing ceased to exist. So I felt very fortunate. I'm not certain what I displayed or how this individual picked up on it. I'm quite certain the messaging was it had happened before. So I was very grateful for that. But the gift again was sitting back and saying, what's important to me? What do I want to look back and say that I've done? What are my value systems around work that I do? And how am I going to go home and feel satisfied at the end of the day, even if I'm getting discounted at the decision-making table, even if I'm dealing with the isms, even if I'm sitting back and being diminished. What will make me feel as though I have job satisfaction? So again, it was a very tough period, but it was a gift to be able to have, because I've used that throughout my professional career in terms of making choices. And ultimately, 25 years ago, when I formed my firm, that was one of the tough choices I had. I was getting recognized and rewarded for work I was doing. I was on the upward level. I'd been a CEO. I was a senior executive. And I said, this isn't fulfilling me the way I thought. And I wanted to get off that ladder. I really wanted to get off that ladder. And people were saying, you've got to be nuts. And in looking back, I was nuts. But because of what I'd gotten through early in my career, it made sense. And I had faith in my judgment. And I know, like many of you, when you make a career choice, it's not forever. You might get bruised, you might break a bone or two professionally, but it's not forever. And I think I had that resilience and experience to be able to take the chance and really build much further on what I've done historically and be much happier with the next phases of my life that were very important.
I love that. I appreciate how much you're both sort of sharing and being vulnerable about that, and that focus on impact. I would say that resonates with myself as well and my choice and why I'm here today. Being a management consultant, I loved it. I'm one of those people I'm an adrenaline junkie. I like the diversity of it. I like the pace. I loved the work. I truly loved advisory consulting work. But I had a family, and I recognized I couldn't do that as well as I wanted to. My daughter came early. I was like, oh gosh, I am not being a responsible parent. I need to reset this. And I didn't know what to do next that would have meaning for me, because I wanted to do something, again, that would have impact. And so I got really fortunate in that a faculty position opened up here at Berkeley. And I thought, oh, this is just for a couple of years. I don't want to fall off track. I want to continue to climb the ladder, chase the brands. I'm going to come to Berkeley. I'm going to teach and do a little dabbling for a couple of years, keep my hand in. And then as soon as my kids are in school, I'm going back. Clearly that didn't happen. 16 and a half years later, I'm still here. And part of it is a similar recognition of how does one have impact? And when you reshuffle what matters, to me, it just became much clearer that working with every single class of students that I've been privileged to work with in the time that I've been here, that's my impact. What I've been able to do and being part of their lives while they're here and beyond, shaping that, forming that, and learning from them enormously as they pass through, and then passing that forward to the next cohort and the one after that and the one after that. That's my impact. And I learned that there's no need to go back out to industry and chase a C-suite title or do something that I thought was absolutely my goal. Doesn't mean I won't still do it. But I recognize that actually my impact was so much more profound doing what I was doing, and I have a dream job. When the 50th person says, I would love your job, and you're like, well, you can't have it. It's my job. And so for me, it turned out, well, how else will I stay relevant and give back? And I found ways outside of the job, so in volunteerism. And so I joined boards. I'm active in my community. I'm now the board chair of a hospital in San Francisco, and I've served on that board for 10 years. And so I feel like I've been able to engage in that almost consultative environment outside of my core professional role. And I think that helps me both in the classroom and in what I do for the class. But it's also just been honest into my true north, which is let's just be real about where impact actually happens. And the number of lives I touch and the number of people that I feel I've had a small role in getting them where they're trying to be through their graduate education and beyond, that's my legacy, and that's really what matters. And I'm so proud to be here and still be part of this organization, this institution, and be part of so many people's lives. So for me, that's kind of what settled in the impact that I and the journey that I chose. But I think you can hopefully hear some really powerful themes across all of us that we're really passionate about making a difference, challenging the status quo, working through different types of both life events and adversities to continue to have these meaningful careers. So I would love to sort of shift directions and get us into some of the topical influences and things that are really potentially shaping what happens next. So we've given you a little flavor of the history of the program and of our journeys. But there's some major things happening right now. We're all here today, and probably why we're enjoying this event in some ways so much is that we've been able to be together in a very long time. I got to participate yesterday in a bonus commencement for the full-time MBAs who graduated in 2020 and 2021 and had no commencement. They had very little of anything during their time here. And so the school really stepped up and had a beautiful ceremony and event yesterday. And it was just profound to see the joy of people being able to come together. And I know we feel that today and throughout this alumni weekend. And so I thought we should probably talk about some of the impact that the pandemic and things we've learned through it and what we think that shapes for us around health and healthcare moving forward. So Julie, what are your thoughts now about what you see for your clients and just your general lens of let's just maybe start with the pandemic. What do we think are the takeaways, the durable change as it relates to health and social impact from what we've all been through, this sort of global situation?
Well, I should start by saying about 65% of my clients are healthcare and 35% are an amalgam of everything else, social sector, food service, you name it. So it's very diverse. I think the thing that we see most often is that the pandemic's impacts, regardless of the industry, have been pretty consistent across all of those sectors. And one of the challenges that we had was trying to support leaders with a lot of ambiguity and a lot of change. So even though we feel like our clients are very proficient at that to begin with, the pandemic changed that substantially. So individuals were trying to navigate their team's needs, their patients' needs, their customers' needs, all while not knowing what the next day would hold. So I think in terms of trying to support individuals, learning that they not only need to be agile, but comfortable with ambiguity. Ambiguity is just the way it's going to be moving forward. And being comfortable with that, taking chances and understanding that if the chance or the call was wrong, stepping back and figuring out how to reconfigure. Change is huge. So the pandemic raised a lot of opportunities, particularly in healthcare, for the provision of services. So whether it was telehealth, whether it was about innovating quickly because you didn't have time to sit down and figure out a business plan and how to put it together and have a small experiment and small tests of change, being able to innovate very quickly was something that was important. Culture change. So most of our organizations, culture was blown up. You weren't live to be able to interact, and figuring out how to hold your core values from an organizational standpoint and support individuals moving forward either virtually or in a way that made sense from their job impact. And then finally, equity was huge and still is. So I will say that when working with most of my direct care clients, that issue was always present for them. With respect to disenfranchised populations, care that was differentially allocated to people, and the pandemic just made that worse. So I think that one of the things that I have seen that has made me very hopeful is that there's been a lot more innovation, a lot more honesty about those inequities, a lot more understanding that just leveling the playing field is not going to give patients and customers in healthcare what they need because those needs are different. And understanding that just in and of itself, leveling the playing field is not going to improve access, is not going to improve equity with respect to provision of care, or drug manufacturing, or you can go on and on about how inequity is going to be present no matter what. Understanding that and having that front and center in terms of considerations from a strategic standpoint is key. So yay for that awareness. I think the solutions are still evolving. And for me and my group, a lot of that is about helping support leaders ask the right questions, look at their biases, understand how the existing systems may not support where they need to be, and having the flexibility, resilience, and the support for change to be able to try those tests of change to support their overall mission. That's what I would say, yeah.
Lauren, how about you? I mean, I know you already sort of sharing though important and mission-driven the sort of the disparities and equities were. Obviously the pandemic really put a light when you see the access to care, treatment rates, mortality statistics, pretty stark and really, I think for many, a call to action, but now we have to see that all the way through to true action, not sort of performative. Where does that stand for you in terms of where you're sitting at Blue Shield or just your sort of broader lens?
Yep. I always feel like for me, the year of 2020 is the year of, I told you so. Like, I've been telling you this. Like, from a standpoint of health equity, but also standpoint of police brutality, you're talking about things, a light being shown on things. It's like, this is my entire lived experience. So it was the catch up of being in meetings at work where people are like, we really need to focus on disparities. And I'm like, I have shaped my entire life and made sacrifices and moved across the country and quit my job and done all these things because this has been so obvious to me since birth. So what a tremendous luxury for this to be a revelation in 2020. So for me, I think it's definitely work being picked up that was already being done but being accelerated. When you think about digital transformation, access to telehealth, so many teams and leaders and thought leaders have been saying we have to do this for years. And then you have something like the pandemic, and you have a decade's worth of work and transformation that magically happened in 3 months because it was prioritized. So to Julie's point around how businesses are prioritizing certain strategic decisions down the road, you can always do it. It's always a light switch. It's a matter of funding, of resourcing, of prioritization, of willingness to operate in ambiguity and to document the known unknowns and to operate on hypotheses. We think this will move the needle. But often what I find is the largest barrier to driving impact in the area of social justice, health equity, social determinants of health is you don't understand the macro, the meso, the micro moves that will actually create the impact you want to create. And so from a strategic lens, I've seen my org and other orgs trying to invest dollars and look further upstream. So how do we think about policy that will impact down the road homelessness? How do we think about education? How do we think about police brutality? How do we think about access? You're down the road thinking about food security and managing diabetes in vulnerable populations. But what happened, what's the generational impact of fear of interaction with the healthcare system that has led to all of these switches, flicking at the same time and moving this person to this current state or this family to this current state? So yes, I feel like the pandemic moved the needle, but to me it was just so blatantly obvious, and I was like, thanks so much for catching up. This is great. Yeah, welcome to the party's right. And I also felt like a lot of the folks that had been at the forefront of these issues and have been telling this story for decades in their work needed to be very intentional around letting others tell the story, letting others fight, and taking a step back and focusing on self-care. I was pregnant at the time with my son, so I was looking at all this happen, pregnant with a little black boy, and I was just like, yikes, I've always been aware of this. It's a new level of awareness for me. So I think right now what my challenge is, before I reinvent myself and let my credibility create my own consulting firm like Julie, is really thinking about how organizations can pivot as quickly as they did with COVID anytime. So for our CEO to say, stop everything, this is about shots in arms, for so many healthcare companies to take a stance to say, no one, you have to be vaccinated to work here. Doesn't matter if you're interfacing with patients. We need to be able to move that quickly and have that level of agility and be able to see the circuit board of this is our macro objective. These are all the key results that we feel we need to add up in the equation to reach that. And at any point, if we flick a different switch, these go off, these go on, and that's strategic planning. So how do we get organizations to think less about activity? And I launched this platform, I did this project, to really, how are you driving impact for communities, and what is your brand, your stance on where you need to play in that area from a long-term perspective. So these are some of the questions I'm asking myself now that I have made it into the rooms that people are listening to my voice. And I'm really looking forward to, being able to make that impact and have my voice be heard. Like, have we thought about this? So for me, the pandemic has only opened doors for the right conversations to happen and for the best thinkers to now finally be in the room and be brought to the table on some of the issues.
I love that. And for me, it's also organizations getting out of their lane. I feel like there was such a rigidity and silo. We talk about data silos, but there's also been this sort of accountability silo. Well, I'm a healthcare provider. Your housing is not my problem. Or, this policy that affects economic insecurity or universal wage. What do I care? I'm in a health insurance company and you come to me to buy insurance. And I think there is this recognition that these problems don't get solved if everyone stays in their silos, that it doesn't matter where you sit, or even if you sit within healthcare, these are societal and generational issues. and how do we come out of that? And we're starting to see some of that. The question is, will there be that continued funding, that continued visibility, that continued priority, or do we move through this like a phase like we do many other things? And I think that's really the challenge, and I think that's the point of keeping the voices elevated and in the room, is that it would be very easy to backslide into normalcy. The system really rejects change. A couple other things that I just wanted to add to both of these for me is that where I sit as the board chair of a hospital, I'm incredibly concerned about our healthcare workforce. I feel that the burnout and the loss that they've experienced, I will call it the emotional trauma, is profound. I mean, mental health generally is something we're going to be reckoning with. We already were, and the pandemic has brought us to a new place, whether you're talking about adolescent, but just to localize on the conditions of care providers, first responders, what they've been through, the leaving in droves, that's a real risk for us as a system. If we make it difficult for people to do what they do, we don't show that we care, we don't stand up with actually, I think, meaningful, tangible ways to help them bridge where they're at, we're in trouble. And I know lots of organizations are documenting this and looking at it, but I think we are in a world of hurt if we don't really come up with something important, because in my own hospital, we fully recognize the burnout, and we're sort of like, well, what do we do? You know, do you pay people more? Like, what do you do? And I don't know that we have the answers, but we need to do more than just like catalog it, talk about it, survey people. And I think that is something we're going to be reckoning with. And then I just think on the general public health infrastructure, we learned through the pandemic a couple of things. One, we massively underfunded public health in this country. It's sort of off to the side. It gets very little funding. And when we need it, we can't easily activate it. And that it's not plugged in ways that it needs to be. And now, unfortunately, we have to have a conversation about what's truth, what's science, and what to do. And a reckoning, I think, that when we were faced with a global pandemic, we didn't necessarily choose a communitarian approach. And now, we just talked about, now we're all sort of each on our own risk calculus of how we feel today. And on some level, we can manage to that, but we're not really sure how to move forward. And most people would say this was not our only time dealing with this situation. So what will that look like? And will we get less and less able to be open about it? And do we get burned out even on pandemic? And so for me, I'm really hoping that in addition to legacy stakeholders really looking at the important issues that the pandemic shined a light on, that we knew were there, we also have to think about how we're going to shore up the infrastructure, and whether that's innovations like precision public health and data platforms and really being better plugged in and thinking about way more touch points for care and for access and for support and data sharing. We have a lot to do. And again, I fear that we go back to the status quo and we ebb away with that. So I don't know if you guys have any thoughts about either of those.
I think it's challenging because, and I'm assuming some of you have more information on this than maybe the three of us do, but the percent of gross national product spent on healthcare is greater now than it's ever been. And we have things to celebrate like the Affordable Care Act. We have things to celebrate like the expansion of Medicare and certain programs that help with chronic care issues. And yet our healthcare outcomes are still awful, very, very poor. So that tension about providing more and not getting more from a quality of care standpoint is an issue. Access is still an issue, so we're spending so much money on healthcare, and we have communities that are devoid of health systems or devoid of practitioners that will support care needs there. So I agree with you. I think that that's been an ongoing problem, and you all and people here are sitting down and struggling with that with respect to what do we do now, especially given some of the impact of the pandemic, and seeing an ability to move forward in a different way to try to address some of those systemic issues. That has not gone away, that's never changed, and it's contributing to huge amounts of inequity that are going to catch up with us as an organization and also as a country.
Yep. And I love that you brought up kind of measuring the impact of what you do. I feel like I'm off. Am I off? I'm on. You can hear me? Okay. And you brought up data, because I think that not data sharing, but interoperability between different sectors in healthcare, between payers, between physician groups, there has to be force functions for that to occur, because you can't measure the impact. You have no idea if you're making impact, or if you can really say that a value-based care arrangement will drive the quality outcomes that you want to have if you can't access the data. And a lot of organizations are now focusing on health equity, but back to what we were talking about earlier, the different points in the continuum, whether it's policy or on the ground delivery of care that you want to impact, how are you going to think about data moving? You move something here that will impact someone 20 years later. What are the longitudinal studies that exist? By the way, they don't, because we haven't prioritized public health. So I think we're in a time where it can be the flavor of the day. It can have, like the word diversity, the word innovation, like so hot topic in their own eras, and now it's like it can mean a million different things, thus often can mean nothing. Is health equity going to become that? Or are we at a point where we can say, if we really care about health equity, if all these new executive positions focused on health equity that have been funded in the past 2 years in response to the pandemic at very large bureaucratic organizations, they're actually going to have the impact that was written in their job description. What do we need to put in place now from an infrastructure perspective to drive data collection, to drive decision making, to drive the loop back on, did we really make the impact we wanted to make when we invested these dollars? If not, how do we pivot? How do we figure out how to make the impact? I don't know if those questions are being asked. I know we're still asking them. We've always asked them. But that's kind of my concern. So I remember sitting on so many Zoom calls in 2020, just, I'll loop back with you in 5 years to see if, your tears on this call are real. Like, are you really going to do something about it? Or are we as an organization, when it's not commercials and publicity and standing up and, politicized almost, when this is real life impact for vulnerable populations, are we going to make the investments in that infrastructure? And some of the investments have nothing to do with health equity. It has to do with payers being what we call brilliant at the basics at Blue Shield. It's like, can we pay providers on time? Can we, and every company is dealing with these things. Can we have accurate data for our members? Can we, make sure that folks are on the right product, or data is dynamic, our strategy is dynamic yet sustainable? So I still have the open question. I'm trying to be optimistic, but.
Well, it is tricky because we're asking for really transformational things, and yet a lot of the basics are still not there. I mean, there's stories all the time about how we're still using fax machines in healthcare to send referrals around, and we still are sort of trapped in a space at that basics level where we're not yet actually taking advantage of. And on the other hand, we're talking about innovation where, like, all of a sudden you'll be able to speak into a microphone and it'll be able to tell if I'm early stage Parkinson's or not. Or smell the breath and tell if you have cancer. I mean, when we talk about this in the classroom, what's exciting for a lot of the students here is really the level of innovation is quite profound. But as we are aware, it takes quite a bit to pull that innovation into this system and to do it in a way that adds benefit for everyone. And so what I love about teaching right now at Haas is that we really are asking these tough questions of how do we celebrate the amazing innovative things that are happening, and how do we sort of appreciate these dialogues are taking place, but how do we make sure that we see it all the way through? And I love that the students are so passionate, and they're actually voting with their feet. It's interesting to see where people choose to take jobs now and what they want to do, and that they're being very thoughtful and critical about the business model, the priorities of leadership, what's being funded. They're not just going to go necessarily to the top brand name at all anymore. This group is really keen on solving the problems, and they're going to go where that's happening. And I think that bodes really, really well for where we are next. Just speaking of innovation, before we turn it over perhaps to the audience for some Q&A time here, is there something that's exciting that's happening on sort of the service or biomedical or digital innovation that you think is really going to revolutionize, sort of could have come out of the pandemic, or just something that you see? I know some people are interested in, biosensors to allow people to age at home, or this whole hospital at home movement. Others are really excited about we can print cartilage and drugs now with 3D printing. a lot of service innovation and rethinking how we serve people, and with very specific models like Folks and TIA that are very, specifically trying to meet the culturally responsive needs of populations. What's exciting to you two?
Yes.
Yes, I would say from my perspective, all of that is great. But one of the things that I'm passionate about is the leadership to be able to take advantage of that,
Sure.
Fill the gaps, provide the services to individuals, deal with the change and the innovation in a way that they can be quickly disseminated or replicated. Yeah. So I think that's one of the exciting things that I see people rising to the occasion with respect to building agile organizations, building organizations that can readily disseminate best practices, successful practices, technology, diffuse it, absolutely. So sitting down and saying that these are core components and understanding that they do have to become change experts and investing in themselves that way to be able to make that all happen, because just having the technologies in and of themselves does not mean that they're going to be a solution for the issues that people encounter in healthcare.
Yeah, so I think you're talking about service innovation, which I think sometimes gets kind of brushed aside and the shiny, flashy things, but without what you're talking about,
without
which is being innovative
leadership.
in that, the leadership innovation, the diffusion of innovation. Love that.
Yeah.
Making the company innovative.
Yeah,
Absolutely.
Yeah. You said digital and biomed. So for me, from the digital perspective, it's very simple, but I was so thrilled to see out of the pandemic how easy it was for people from vulnerable populations to connect with providers that they can relate to. And it's sounds so simple, but being able to connect with an OBGYN who is a Black female, and it may not be in your area, or being able to get immediate answers to questions that you have. To me, a lot of the technology that rolled out over the past 2 years was like, yeah, we've been interacting this way with Amazon, since they launched delivery of packages to our home. And I'm really looking forward to the forced innovation around digital transformation, now just making accessing care easier for vulnerable populations who are working multiple jobs, who may not be able to pick up a random call. I remember being on a project looking at Latinx members with diabetes, and they were like, why isn't this patient panel able to pick up a random call from their care provider and give us their readings and stuff? And it's like, they don't have their phone, they're working, It's like, yeah, and it's to me some of the light shown on how great of care you can get access to without having to take 5 hours out of your day, when you may not have access to your own transportation, when you may not have the luxury of calling off work because you're paid hourly, or you may not have childcare for your children. Those were the issues that I was trying to solve for when I went back to school. Those are the issues I was looking at my cousins and my family deal with every single day. So for me, I'm very excited about the simple things, to be honest. Not even the big shiny products at this point.
And I'll just add that what I've become fascinated with is this idea of supporting us in the home and looking at simple and more complex innovations. I feel like we're in the midst of seeing a fairly large age wave. Most people express a desire to be able to age in place, age at home. Some of this is models, service models that support that. Some of this is technology. But I have aging parents. I'm starting to think about it myself. It's like we don't have the capacity to have people in institutions, nor do they want to be. But how are we going to set up for that? And so for me, I'm really excited to see dialysis at home, lab draws at home, the ability to have sensors to know if mom opened the refrigerator today, and what would we do about that? So I'm excited to sort of follow and see. And I love that you see companies like Comcast and Best Buy that we don't think of as healthcare organizations, but they provide products and services, and they have a gateway into the home, and that they see a niche there, and they say well, maybe we can add some value. And again, that lane jumping, that drawing of expertise, that it doesn't have to come from healthcare. There's a lot of other ways, Amazon, whether it's technology, retail, hospitality, lots of learnings there. And I love that we're starting to become more open about that. And how do we think about contributing to those? Because I think given the number of folks who are going to be aging and we're living longer, we're living with certain conditions, ideally we want to have a high quality of life. What are we going to do? The numbers are pretty staggering. And so for me, that's kind of the area. And it is a mix of service and sort of digital. So.
How do we make it financially accessible
Exactly.
to all populations.
Most people haven't saved to the extent that they would need to be in some sort of institutionalized environment. And almost nobody has long-term care insurance, and it's rarely a good buy.
Yep.
Medicare doesn't cover that, and most people don't know that. If I ask my classroom in the beginning of a class, how many of you are looking forward to using your Medicare benefit for nursing facilities, they all raise their hands until I'm like, look, how many of you realize that that's not what they do? Don't cover that after 100 days after discharge. After that, you're on your own. That would be Medicaid. So while you think about what you think about Medicaid, recognize the important role that it plays. People don't know any of that, really.
Yep.
Most people. So the literacy and health literacy and understanding personal financials, savings rates, all of these are much more larger macro effects. But as we think about what is it going to allow people to live the longest, healthiest, high-quality life that they can, how do we support that? So think a lot about that. And in an equitable way so that it's not further marginalizing folks as we move
Having
forward.
to figure it out takes a huge amount of health literacy.
Yeah.
And you're often doing it under stress. You're not thinking about end-of-life care that far in advance. It's scary. And it's even scarier for populations where that is not the norm. There's certain barriers to having those types of conversations. Really depends on your background, your religion, what your family thought was on or off the table in discussion. So yes. Yeah. To your point, yes to all that.
So we have a mic in the center here. We would love to hear from any of you if you've got any questions for us. Fair game, topics we've covered, things we haven't, questions you have about the program, healthcare writ large. Please. Don't be shy. Keep talking. Great.
Hi, thank you.
Of course.
Pete Dillon, class of 2016, neophyte in public health and healthcare. I am at Color Health, which has responded to pandemic needs and has a compelling model. Very fortunate to be there. I'd love to hear any or all of you talk a little bit more about what precision public health might look like.
Sure. Part of that is thinking about a couple of things. One, it's how do you aggregate data so that we're much more nimble and agile than we are. I'm sorry that our colleague Becky Messing-Hagler's not with us because she comes from Verily. And that was something that Verily, which is the life sciences arm of Google, or Alphabet under the Google platform, was trying to do, which was rapidly aggregate testing and other data because they recognize that disparity. And so you can't really do much in a precision format without information tied together. I also think there's just an element of making it real and making it personalized. So what do I need to know? What's my risk calculus? How do I engage with the center, with the data? And what will that look like? How can we think about more companies in that milieu so that it's not just a public health agency, that it becomes much more of a public and private response. We saw a lot of the retail pharmacy chains stepping right up. It was good business for them. Let's not be unclear. But you're really providing vaccines, testing in a way that they hadn't been asked to do in that kind of rapid format. So I do think that there's, for me, aspects of when I think about precision public health that are about aggregating data. If you haven't, Charity Dean's, the public health company is a super interesting model. I don't know if anybody read the book, but she was this, what's the guy that wrote Moneyball and then wrote Michael Lewis. His book about the pandemic, which is really up until the pandemic and really talks about the previous administration's abilities to plan for this and how those were sort of scuttled. But really, what's the life of a public health officer? Localized a lot on California, how it's literally a county by county model, very decentralized, limited power and authority, oddly enough. And then the politics between the state and the feds, and you realize you're not set up for success at all on any level, functional, data, or otherwise. And Charity being, I think the UC Santa Barbara County lead there, and the journey that she went on, both in her own county and the inability to affect what needed to happen. And then she worked at the governor level in the state and saw different challenges politically there. And she's like, we need to solve this differently, and went off and founded the public health company, I think Van Rock backed. And, so I think it's partly creating these additional approaches that think outside the box and not just in a public health agency mindset, not diminishing that, but amplifying and augmenting that with some of what we know we can do from a private sector approach, whether that's a big tech lead in, some of our, product pharmaceutical partners, or just, people who want to come out of that public entity and see what they could do if backed in a different way with a different sort of playing field. Because I think without bringing data together and accountability together and visibility, we can't get to that sense of precision public health. So that's my take.
I think one of mine's responding with a question is, like, how do we focus on precision health that requires so much access to data, so much clarity of data, when vulnerable populations have been left out of the equation for so long? So now what are we going to do to proxy that data? What are the assumptions that we're suddenly going to draw if you're in this zip code, if you listen to this song? No, I'm just kidding. Not that far, but the assumptions that are being made to be able to quickly design and deploy precision health solutions are, in my opinion, really at risk of widening the gap of health disparities. If you don't recognize that you do not have data for all populations that you're trying to influence. There's an assistant professor here that I would totally cheat on my phone to find his name. He came and spoke at Blue Shield, and he blew this up for a very large payers.
Oh, Ziad Obermeyer.
That's it.
Yeah,
Thank you.
He's my colleague in public health. He's
Thank
an
you.
emergency medicine physician and data scientist, and he studies this exact issue, that if you're going to use AI and machine learning either in resource allocation or clinical decision making, you'd better make sure that your data set is representative. And he worked for a large payer, and the findings were that they were using resource allocation off claims data, and who's represented in claims data and who isn't was driving resources away from the populations that actually had the highest need.
Huge delay of care.
And it wasn't intentional, I would like to just point out. It was an unintentional bias, but it was still a very profound bias. He's actually teaching classes to upper division undergrads here, coding in Python. If you're going to go out there and create algorithms in data companies, you'd better do it with a sense of eye to bias. And a lot of the graduate students are now starting to take these classes as well, because he's really concerned that we're going to make this problem worse.
And you will. And it's not from a standpoint, we talked about this before, it's not from a standpoint of leveling the playing field. It's not from a standpoint of just trying to do good innovation. If you do not intentionally focus on bias with the assumption that there is bias as you're creating these systems, you will widen the gap. It's just plain and simple. So
the data sets are already there.
Yeah. And how do you think about, because I asked him after, and he didn't have full information, but I asked him after he spoke, I said, well, was there any person of color that was helping design this? Like, was there anyone in the room that might have asked these questions? Because whatever the bias creation was, he went through it. It was like, to me, so like, duh. Like, if you said this to me, this assumption, I would never connect these things. This is like Twinkies and oranges, like they don't connect. And I think that's the biggest challenge, is who's making the decisions, who are you running it by, and really forcing business leaders to ask the right questions. What assumptions have been drawn? What are the known unknowns? Where are we operating off of hypothesis? What is the time horizon of when we test that hypothesis and we determine whether or not it's true, and we now have a dynamic model that we can pivot when we need to? Because often we launch something, the folks who have launched it, they know where they've bullet pointed their assumptions, and they've created some model, and then it gets implemented, it gets tested, it gets implemented, done. But what's the look back, and what are the measures we're really trying to focus on? So I'm so excited about it, especially being a bioengineer by training, and so terrified that it will, if not done well, make it worse.
Parallels to medical research in terms of excluded population, marginalized populations, but the potential is great.
Yeah.
We're starting to see this too, by the way, just in like clinical trial diversity. I mean, I think what's exciting right now is this really strong recognition and commitment that across the board we've been leaving people out of the key data sets, and whether those are old Dugard data sets, claims data, or this new world where we're realizing that clinical trials are basically based on white males.
Yeah.
So women are left out, people of color are left out, and that we're now being thoughtful. So we're talking right now about AI and algorithms and process, but it's also, there's been a huge, I think, shift in thinking about clinical trials, this movement towards decentralized clinical trials, which is also sprung from the pandemic, and this idea that how do you keep clinical trials going when people can't come into clinic? well, the other byproduct of thinking about that is that who could you then include if somebody's got a job that doesn't allow them to come into clinic and be part of a trial, but now the trial's decentralized, there's supports for people to participate even if they can't come to clinic every day at 3 o'clock, which is impossible for people from some vulnerable, it's like essential workers. So I think we're getting there, and it's very exciting to see that there's a recognition. I will say in the classroom, we're all being challenged to think like this. So when I teach healthcare finance, I'm absolutely challenging the students to recognize, all right, well, who didn't get to provide this financial data? What perspective is missing from this 10-year cash flow forecast to decide whether you should buy a cyber knife or whatever? Like, whose perspective is not being represented? You know, the numbers are the numbers, but it's the context, it's the assumptions, it's the accountability for the look back. Same with strategy. I've been struggling to find versions of all the key strategic frameworks, Porter 5 forces, value chain, that bring any element of lived experience or other. And when they're not there, I just task the students, well, let's redesign them then to bring this in intentionally. And do not forget that you have to, look back on this and see, if you made a decision based on faulty data, how could you fix that? How could you remedy that? It's really had some really interesting classroom discussions now, and the students walk away, just to your point, it's oranges and Twinkies, but we wouldn't have seen it had we just learned the framework as it's been classically taught. And so I do think even in the classroom there's a role to play of challenging the status quo, which we try to do, and sending students out as future leaders, making sure that they are holding people accountable, asking these questions. So it's a big part of what we do. So that's another question.
Did that answer your question?
Yeah, perhaps one more. I know that we don't want to keep you from break, and then Hossack. So.
Hi, Scott Becklevin, MBA 92. I have a question as it relates to pharmaceutical and medtech companies driving innovations at scale versus providers and payers. Very often, from a pharmaceutical perspective, they actually have a longer-term perspective than payers do. And I'm curious, especially from your perspective, how do you solve the sort of 2 to 3 year assumption that people will change their health insurance so you get longer-term incentives to be able to actually invest for those long-term innovations that it takes time to measure and see the outcomes?
I feel like that is a huge challenge. My perspective, and I will say what I love about leadership at Blue Shield, also at Kaiser, is there's a difference between trying to invest and fund innovation that impacts just your member base and trying to fund change that transforms healthcare as a whole. So from a strategic perspective, there has to be focus on, we will change healthcare in California. We will change the value-based structure for payers. We will move the needle on health equity for brown patients. Like there has to be a broader lens, because you're right, the switching costs between orgs is super low. And then the front end of your question was around pharma and the longer term view on investment. And that was part of the reason that I was excited to work on things kind of closer in front of my eyes, is because it's often a shot in the dark, and a lot of Kim can super speak to this because I learned it in her class, but a lot of the cost in pharma and in med devices is because you don't know in 15 years what will be the emergent application of a drug, or what will get you the most funding, or what your competitors will come out with, or what will work and what won't. So a lot of the spend is hedging your bets and investing in a ton of different things. And I think that the decision of what moves forward that was one of my personal struggles thinking about health economics, was the decision of what moves forward is often based on what earns the most revenue, because these are for-profit companies, versus what is the most vulnerable population. It's why we had the first advancement in treatment for malaria decades later, because it's not impacting the bottom line for all these pharma companies. What will get reimbursed in the States, where they get more reimbursement than other countries. So I think it's not only the finger in the wind of what happens in 15 years when it comes from innovation, but what is profitable innovation in the way that we have aligned our P&L. which I have significant issue with. So it's very challenging, but I don't know if you have more perspective.
Yeah, I mean, I think you're right. I mean, you have these horizons that don't align with other business pressures. And so you have to, it has to be a leadership decision to think around that. I think you're starting to see pharma do that a bit. I mean, there's a lot of been blowing up of operating models, commercial. I mean, Novartis is going through a big change right now. They're going to lay off a lot of people. They're changing how they think about it. Genentech and Roche went through it a while ago. And I think it is this appreciation that they need to move faster and be more agile, but they also need to have these through-line threads that think about what are we doing to change things more broadly and think of it as portfolio, not product line.
Yep.
Or therapeutic area solely. You can't unhook from that. They are mostly for-profit, publicly traded. But to have enough of a through-line strategic, and that comes from the leadership. You need someone, a team at the head that it's willing to invest in that. And I think also we talk about this a lot, coming up with other ways to fund R&D to take some of that transfer pressures off the pricing. There's a lot of models, I think, that are being discussed, innovation prizes, other ways of funding R&D would also allow that to change so that you don't have to have the current pressure today to have the highest price possible on a drug to fund the drug of tomorrow and fund the failures. And so I think when we actually, again, go upstream, you would see some more change in that. But I'm sorry we have to bring this to a close because it's really interesting. Hopefully some of us can sort of hang out a little bit after, move it down into the courtyard. I wanted to thank both my wonderful panelists, Julie and Lauren, for their willingness to share and just be vulnerable today and to come and be here.